and we will eliminate trachoma. And we will do it with the same kindness and passion that they both did. And I suspect they're both there having a chat about how we should be doing. So I just ask you to join us in that today. So, very briefly this morning, we're going to be, there's your welcome, best welcome ever. We're going to have a quick look about ICTC for those of you who have not been to a meeting yet or before. And we'll have a look at the preferred practices. Then Hannah will lead us through the progress that we've made in the last year. And then we'll have a very quick panel discussion with wonderful people here. And then close the open session. We'll try and make time for Q&A. So if you do ask a question, please just introduce yourself, your organisation, and then we'll know who you are. Become more of a family. So without that, I'm going to pass it over to Angelia, who will do this.
Great, good morning. Look at where my screens are. So, just to give some background, first of all, we're very excited to have this open session because ICTC is members and observers only. Most of our meetings are always closed, and we thought that NNN was a good opportunity to explain who we are, maybe for those of you from organizations that are not members, it'll make you interested. And this way you also know a little bit about what we're doing at the international and also country level. So ICTC control was started in 2004, which makes it exciting that next year will be 20 years that we've been working as a coalition. And our main priority is to support the WHO Alliance for Get 2020. And so we are here to help the World Health Organization help countries. And we do that through supporting each other, discussing our needs, finding ways to work together. We just launched our new strategic plan last year. This was something that was discussed at the last NNN. And this covers the period from 2022 until we eliminate trachoma by 2030. And it's really about how do we support countries and partners to reach those goals. You can see our vision is the global elimination of trachoma by 2030, and our mission is to assist country governments and other stakeholders in the implementation of the SAFE strategy, which I hope everyone knows the SAFE strategy, in support of the elimination of trachoma. And in order to carry out our vision and mission, we have 4 strategic objectives. The first is mobilizing advocacy, finding ways in order to promote country programs and promote the purpose of eliminating trachoma. So whether that's approaching, attending meetings like this, donors, really getting that messaging out there. Also increasing investment. We know that every time we talk about what are the challenges of trachoma, one of the first things is we need more money. So how can the coalition and its members help to increase awareness of the problem, motivate governments to either be donors or host governments, national governments, to invest in the trachoma program. We also coordinate the provision of technical assistance. All of you in here are very smart. You have a lot of ideas. You have a lot of lessons learned. And so we try and create documents and resource materials that takes that knowledge and make sure that it's shared. And we do this through things like the preferred practices, which I'll discuss next. And then also just working that we have an effective coalition model, that we're constantly trying to work together. Does this work? No. I can be very loud, so. And, oh no, because of the online. It was. Hello? Hello. Okay. There we go. That was the good shoulder. This one's the bad one. So that we all work together. And I think we all know that it takes effort to get along. And so just finding ways to share information to make people feel included and that we value opinions. ICTC, well, how ICTC works, you saw a little when Michaela introduced our group. We have the executive group of the vice chair, chair, and immediate past chair, and that's something that's member elected. So Michaela and I were elected to our positions. These positions are every 2 years. So the executive group are people who have been on that group by the end for 6 years. And then having the project manager and also having communications support, which I know from those of you who might be in other coalitions, I would say this is something that really helps Trachoma achieve its outcomes. Having people like Aparna and Tim make a big difference. So if you're thinking about coalitions, having everyone volunteer is good, but it's nice when you have 1 or 2 people who are paid to help support the work. So that's a recommendation. And then also, at the end of the day, you need people who actually are committed to helping do some projects. And so we have our member representatives and our observer representatives, and all of these people frequently are part of task teams or working groups. So we may say, all right, we see that there is a problem with mobile or migrant populations. What can we do and work together in order to address this issue? And we actually have that task team, which I'll discuss in a minute. Or maybe surgery. We're struggling with what is the best way to provide surgical services, or what is the best way in order to help countries transition from an active program to one that has eliminated. And so you bring the members and observers together to work on special projects. All of this, again, is to support the WHO Get 2020 Alliance. Like I mentioned, the preferred practices, one of the things during our strategic planning process, we interviewed members, observers, ministry people. There's some ministry people here I remember interviewing. And I asked them, what are things you like about ICTC? And they said, the preferred practice, having a document that makes recommendations across the countries. And they found that having these documents actually help them advocate to their governments, because they might have a supervisor that says, why are you're doing it this way and not this way? And being able to say, well, this is what's been recommended based off of experienced professionals. It made it easier for them to have those discussions within their country. And the same with organizations. We found that a lot of donors will say, how are you making decisions about your program? Are you using ICTC preferred practices? And so this is something that we find is a very important tool. All of this is on our website. We also have them printed in some cases. And the good thing is, though they're all in English, many are also in French, and some are in Portuguese and Spanish. And that's something that if there's a really good preferred practice, and there's a need, we're able to translate it if we have funding to support that process. Because we realize we need everything in more than just English to be helpful. And then just briefly, with how we develop preferred practices, like I said, it might be a situation where we've identified that there is a problem. People really want some documented information about something. And so we'll meet, make a decision about, is this something we want to spend time doing? We'll form a technical advisory committee to give technical input and advice. We ensure there's no competing interest. And then we go through the process of developing the preferred practice, getting it endorsed, and then making it pretty so that we can then publish it, and if there's money, translating it to other languages. All right, so with that,
I'll take that one. Thank you very much, Angelia. Just to add, on the preferred practices, these are technical resources that ICTC's members have been working and building on since 2012. So we recognize that a number of the technical resources, in some of them, they're undergoing a review to see which ones would benefit from updating, especially as many of them will be over 10 years old now. So that's something we're currently looking at. So in terms of wanting to look at some of the progress the coalition has made as a community since last year's NNN. According to our 4 objectives, in terms of mobilizing advocacy, ICTC worked with the Vision for the Commonwealth Campaign Initiative, which is a campaign initiative composed of a number of eye health organizations, including colleagues from Sightsavers, Fred Hollows Foundation, and the International Agency for the Prevention of Blindness. And together we worked on an advocacy strategy to influence the Commonwealth Heads of Government Summit last year, 2022, which you will know was hosted by the government of Rwanda. Part of that advocacy was really to build on the political momentum from 2018 to have a political commitment from Commonwealth member states to eliminate trachoma and also to expand on their commitment for universal eye health coverage. And so that's something we have been working with colleagues to ensure that commitment also was reiterated in 2022. We've also been working through the ICTC task team on special populations to develop a new mapping tool which has already been piloted in several countries, really to be able to gain a better understanding of where special populations may be located in different countries. And by special populations, within ICTC, we particularly refer to refugees, internally displaced populations, indigenous communities, as well as nomadic communities. We've also been using that mapping tool to be able to collect case studies to showcase how programs have been able to adapt to meet access requirements and treatment programs for trachoma. And so we currently have already a case study from Colombia, which has been published in the Community Eye Health Journal, and we hope to publish additional case studies from Zambia, Tanzania, and Ethiopia in the next week or 2. When it comes to our objective number 2 around increasing investment, we know the NTD and trachoma landscape has changed a lot in recent years, whether it's in funding, whether it's through the impacts of the COVID-19 pandemic. And so we have started efforts to update our understanding, not just in terms of the needs of health ministries, endemic countries, but also understanding the reach of ICTC members and observers. So to clarify, for ICTC to be a member, you would be an NGO or civil society, an implementing partner, part of research academia. To be an ICTC observer, you would typically be a donor, industry, but also WHO sits as an observer on ICTC. And so over the last few months, we have focused on gathering updated information to understand where ICTC members are operating, what part of the SAFE strategy they are delivering in different countries, and we have collected that data at a national level. We've also recently established a new task team to conduct a gap analysis across the global trachoma program, and I'll be sharing a little bit more information on this group a little later on. So they will be responsible for gathering an updated understanding of gaps across resource mobilization, gaps around technical expertise, to really understand where can ICTC as a community of trachoma stakeholders really best support national programs. So this map kind of shows some of the outputs from the member survey to understand the geographical reach of ICTC members. And it was really helpful to get an updated perspective and view of where ICTC members are working, how countries are progressing towards their elimination targets, and we hope that resources like this updated map, which we'll look to continue to update on a regular basis, can be useful to members in their advocacy efforts to also demonstrate how the trachoma community works together in a coordinated approach. And then looking at Objective 3 around the coordination of provisional of technical assistance, The provision of technical assistance is particularly focused amongst trachoma implementing partners. So we know that WHO provides guidance to health ministries. The technical resources that ICTC produces through its preferred practices are complementary tools to the WHO guidelines. They provide the how-to component, utilizing the best available evidence from partners around approaches that they are using to deliver the SAFE strategy. In order to promote the existence of these preferred practices, to encourage people to use them, to adopt them, we are looking at how we share that knowledge and share those resources, also looking at how we publish. So one of the collaborations ICTC has with the support from the International Trachoma Initiative is a Trachoma Matter series in the Community Eye Health Journal. And every quarter, ICTC coordinates with ICTC members to extract updated information, insights, knowledge, experiences from across different countries to share in this journal, which has a very broad readership of eye health professionals from all over the world. And that really looks to support relationships between the trachoma community and the broader eye health community by sharing our experience, our collective experience from trachoma with a broader eye health sector. We also recently conducted a member survey on preferred practices to get a better understanding of how members are utilizing the preferred practices, which ones they use or find most helpful, but also to take a look at which ones members would have a need to have updated. And then also in the last few months, ICTC members have endorsed 2 new technical resources. One is the Women and Trachoma Manual 2nd edition, and the other is a tropical data photography database. So with ICTC endorsement of these 2 particular resources, the Women and Trachoma Manual was developed by a series of ICTC members outside of an ICTC task team. So they involve partners from the Carter Center, from ITI, Sightsavers, and many other colleagues. And with Tropical Data Photography Database, that was led by Tropical Data themselves with their partners as well. The idea of the ICTC endorsement is that through the contribution of members into additional resources and tools, ICTC members have an opportunity to learn about a new tool, but also to vote on whether they wish that to be promoted and included by ICTC as a broader community of stakeholders. And so part of the work that ICTC will do will be to continue to promote the availability of these resources so that stakeholders will be able to use them and find them helpful. And then finally, our objective number 4 on ensuring an effective coalition model. We are always looking for ways in which to strengthen the relationship, the collaboration aspects, and the partnership opportunities between trachoma stakeholders. And as many of you will know, coalitions are built on individual relationships, organizational relationships, and they, much like in our personal lives, require constant work to maintain trust, to maintain transparency, to maintain information sharing. And so with that in mind, ICTC launched a new Knowledge Broker webinar series to build in additional opportunities to share information between us outside of our 2 regular meetings every year. I think what the pandemic has taught us is that while we have increased interactions virtually online, trying to ensure the quality of the interactions can be difficult. And so for ICTC, trying to provide more opportunities for meaningful interactions between members is something we're keen to continue working on and to strengthen. We've also been looking at how we engage the very wide and broad expertise from our membership to offer consultative approaches to inform coalition-wide submissions. So in the most recent last few months, we have conducted a coalition-wide input into an ICTC response to the WHO NTP review, which was earlier this year. And again, coalition members to share their individual experiences, their organizational experiences working with WHO, to share commonalities in the different ways in which we all work with WHO, the NTD team, and aspects we would be happy to work further with WHO. So having a community-wide submission helps us to bring together that wealth of ideas and experience to see how we can support WHO and endemic countries together. And then finally, one of the tools that we also have in terms of supporting the coalition model is also are informed by the Get 2020 database. So for colleagues in the room who may not be aware, Get 2020, the global, the WHO Alliance for the Global Olympics, have the direct involvement of country and member states. So together they collect epidemiological data that is collected by ITI, that worked with WHO. It is country-owned data, but they have provided consent for that information to be published through the WHO Weekly Epidemiological Record. So it is... Okay, thanks. And ICTC... Oh, there we go. ICTC uses that data to develop infographics. So the idea behind this is that we have visual tools that are available to the trachoma community, which provides everyone with the same information of year on year, what does progress look like? How have the number of people at risk changed year on year? What are the numbers of people that require interventions? And its purpose is really to ensure that all trachoma stakeholders have access to the same information. Okay. So in terms of things that we are looking ahead to over the next year, from ICTC's strategic plan, the ICTC community also comes together to inform our annual work priorities. And every year these are updated with input from the ICTC membership to inform how we will deliver on our strategic plan. So this year we are looking at continuing our engagement to influence the next Commonwealth Heads of Government meeting summit, which will take place next year and will be hosted by Samoa. And we feel strongly this is a really exciting opportunity to showcase progress in trachoma in the Pacific, to showcase the work that is being done in small island states in a region that we don't always spend a lot of time talking about at meetings like this one. We'll also be utilizing the evidence and the data from the work of the ICTC task teams on special populations and gap analysis to develop new case studies on safe strategy implementation. And we hope those will be strong advocacy tools for ICTC's members and observers to also utilize in their advocacy. And then we're also building off our conversations with IAPB over the past year and following on from their engagement at the NNN in Nepal last year, look to how we can include trachoma in their advocacy module on integrated persons, people-centered approach to eye care. Thank you, Martin and Chris. And through the task team on gap analysis, we will look to continue our work on identifying the key gaps, challenges, opportunities, and the advocacy messaging that will help us to mobilize resources. We will also look to continue to update our preferred practices and also look at the potential for developing new ones. We have colleagues who are working on securing ICTC endorsement of new tools. These include a new photography training guide and then also an MDA safety manual, which I know a number of colleagues in the room have contributed to. We will also be looking to develop a new preferred practice for special populations to share knowledge and information around program adaptations to support those communities in accessing interventions. And we'll also look at how we can better share information on research through an ICTC Knowledge Cafe. In terms of looking at how we continue to strengthen and mobilize the coalition, we'll continue to engage with our membership on a regular basis to really inform consultative approaches for ICTC into external opportunities, and look to continue to promote and encourage trachoma stakeholders to utilize the free resources we have available on our website. Thank you. And now I'd like to hand over back to Angelia.
All right, so Aparna gave part of my presentation, so that will make it easy. The reason we wanted to discuss a little bit about the Special Populations Task Team in this space is because in addition to being on the ICTC Executive Group, I'm also chair of the Conflict and Humanitarian Emergencies Working Group. And I'm just seeing a lot of discussion sort of within the NTD community about unique populations. So those that, what we are calling within ICTC, and I realize part of the challenge will be everyone has a different term for this group. So it might be the never treated or hard to reach, or special populations. So that will probably be one of our first tasks across the NTD space, is to come around some common language. But for purposes of ICTC, looking at populations that are at risk of not being able to access the services that the NTD is trying to provide, in this case trachoma, and it could be for a range of issues. So whether they've become displaced, maybe because of their tribe, the geography where they live, they may be living in the mountains and our vehicles don't reach. So just anyone that has kind of been left out of the system. Because that includes a wide area, for the purposes of the task team, we're mostly referring to refugees, IDPs, indigenous and nomadic populations. They've also been called sometimes statistically invisible. I realize we are a public health problem, it is a problem. Trachoma is a public health problem, you know, we want to make sure there are not people who are left behind. We get so focused on the end game that there's communities that really deserve these interventions, and we want to make sure that they're reached. So our goal with setting up this particular task team is to really sort of guide the ICTC group and also the ministries that we work with on just how to think about including these groups in their programs, support the success of the program by ensuring these populations are reached, continuing with advocacy to ensure people are not left behind, and then to serve both the coalition's goals and then also those in the community. One of the things trachoma is very lucky is that the Trachoma Expert Committee also has a group, and they have formulated sort of a plan on making decisions about how to approve drug for example, people who are displaced. So maybe there's IDP camps or refugee camps, and this has been very helpful. So on one side, we're lucky when it comes to the drug allocation program, we have some guidance. But we wanted to take it further beyond just drugs and also kind of get more into program implementation. I don't expect you to be able to read this well. This is actually an Excel sheet that goes all the way across. And the first step is, how big is the problem? We keep saying refugees are a problem, IDPs are a problem, this is a problem, but what does that mean? And if you're trying to get money from donors, or if you're trying to advocate to governments, they want to know numbers. And so what we did is developed this sort of database to collect information. Who are the groups? Where are they living? What's the population where they're living? What's the population of those groups? Does the population, the host community, have trachoma? Does that group have trachoma? Is there any published information? Have surveys been done? Where can we get information about this group? And by starting to compile this from countries, we start to get information to have a sense of, okay, what are we talking about? And the task team created this tool, and we have it in English, French, Spanish, and Portuguese are the 4 languages. And we've started reaching out to governments in order to fill in this information. So for example, I got permission to share from the Sudan program. They had done trachoma work in South Sudanese refugee camps. And so we included the survey information, the years of intervention. Similar, there are Ethiopian refugee camps. We've gone and collected that information, and we filled it in this tool. So some of the country programs here, you may be getting emails from maybe an implementing partner asking if you're willing to help compile this information. I know, for example, in South Sudan is hosting, they have IDPs, also refugees. Knowing the numbers can make it easier for partners to advocate for additional resources to support reaching these populations. So that's one thing. And also, as was mentioned, collecting case studies. That's one of our initial activities as well. And it's not a matter, we show here the 4 countries where we've collected case studies and we've finalized it, but that's just one case study about one thing. The SAFE strategy is multiple strategies. The groups within a country are multiple groups. So for example, in Ethiopia, we might want a case study on the work that RTI has done with the ministry in the Gambela area, because they've been working with refugee camps. We also might want information about conducting surgeries in a certain context, how to reach areas that are mountainous. That's a challenge in South Sudan. So the idea is, after we have a good number of case studies, I don't know what that number is yet, and we have a lot more information on the inventory, let's see, I'm going to come back to that one because I'm on a roll. So what we'll do is, after we have the population data, the case studies, we'll then develop a preferred practice. So what are all the things that we've learned? If we notice themes from across the case studies, and this relates, we also will pull information from other groups. So for example, the Conflict and Humanitarian Working Group, they've been collecting information. Core NTD and the conflict group earlier this week had a 2-day meeting where they looked at mobile and migrant populations. And we were able, as part of this workshop, to have non-NTD representatives. So we had IOM, International Rescue Committee, perspectives from ESPN, WHO on the One Health. We had people from the government of Mali, from the vaccination program, because there's things we can learn from the vaccine program. And we brought them together to discuss what are the challenges, what are ways to overcome. So you take the information from this area, you take the information from the case studies, you take the information from your gap analysis and say, what is the problem? What do we know? What don't we know? What are things that work? What are things that don't work? Because we don't want to repeat mistakes. What are unique examples and case studies? Have that in a preferred practice that can be shared among the trachoma community. And I think we'll see that trachoma lessons learned will likely be adapted to other NTDs. So one of the things is that trachoma should be very proud. It tends to be at the forefront. So while people are having these conversations, already trachoma has been collecting the data, collecting case studies, and starting to move this forward to something that's tangible. And so hopefully this will make you excited to be, oh, like, I have something in my brain. And if you do, tell us, and then we'll sit down with you and we'll document what we know so that we can get that information and learn from each other. and develop tools that can all help us sort of move forward. This is some of our members, past and current, and like I said, upcoming activities. So for those of you who are ICTC members and observers, if this task team seems very exciting to you, please let me know. I've put my email. Chad MacArthur is my co-chair, and we will have our next meeting likely in October or early November. We try to have a task team meeting about every other month, and especially now that we're starting to really move forward on the preferred practices, we'll start having more. My goal is to have a draft, I'm going to say it here so you can all like wag your finger at me at Next NNN, like by August. So, but in order to do that, I need information from all of you. So when you get an email asking to be part of the case study, please respond to me and say yes. All right.
I just wanted to highlight the wealth of information ICTC has been receiving from the inventory tool, from the interviews, through the ICTC task team on special populations. Isn't just capturing, although the focus may be on trachoma, it's also capturing a lot of other aligned activities. In Colombia, for instance, we've received a whole wealth of information because in the Pajo region, there are broader policies that are encouraging multi-disease initiatives because they are reaching really quite hard to reach indigenous populations who have logistical constraints, language constraints. And so we're gathering a really broad wealth of information. The case studies, as Angelia mentioned, is also looking at lots of multiple aspects. So not just across safe strategy, but also with trachoma and how it is working with other disease initiatives. Similarly, with some of the other country case studies and information coming in, when it's looking at nomadic communities, nomadic pastoralist communities, we're receiving information on how communities are using One Health approaches, how trachoma interventions can be coordinated with those approaches as well. So just to say, although this is for a trachoma coalition, we're gathering a wealth of information, and we're really welcome the inputs you might all have on your various disease programs and communities you work with, and how can we look at the ways in which they all interact with one another. Thank you.
Thank you very much, Aparna. So we'll hold questions till the end of the session today, because we know we've got a very short amount of time. So with that, and hopefully in a more composed manner, I'd like to invite panel guests up for possibly the most intimate panel discussion we've ever had at NNN, such a tiny room. I'd like to welcome my guests up to the front. We're just going to drag our chairs across. Just about. Squeeze in, I think, can't we? Thank you. So, welcome everybody, and thank you very much. Again, this is going to be a bit like speed dating because we don't have much time. We do want to draw out some fantastic learnings and experiences, though. And we wanted to really just discuss on strengthening links between NTDs and eye health systems. So we know that several neglected tropical diseases, not just trachoma, but onco and ocular leprosy, can lead to preventable blindness if not managed properly. And in recent, well, more and more now, we focus on the collaboration between existing eye healthcare systems, as well as the public health outreach campaigns that we're working on to get closer to elimination. In 2018, ICTC developed one of the preferred practices that we've talked about on transitioning services back into healthcare systems once you've achieved elimination. But we know that actually we should be starting early, which ensures sustainability. This is our favorite new acronym, so we do hope it'll take off. And it helps us to think through early approaches and collaborations between NTD programs and eye health units and other components of public health, services to ensure the sustainability of impact of interventions. But has that been the reality, and are there still challenges? So I'm going to invite our fantastic set of speakers here to discuss some of these aspects. But before we do that, I'd like you to please introduce yourself to the wonderful trachoma community here, starting with yourself.
Thank you so much for the opportunity. My name is Wycliffe Omondi. I'm from the Ministry of Health, Kenya, heading Vector-borne and Neglected Tropical Diseases Unit.
Good morning. I am Teil Wambio Michelia. I work with Site Savers as the coordinator for trachoma in Nigeria.
Good morning. Thanks for the opportunity. My name is Francisca Olamiju. I'm the executive director of Mitosat and the chair of the NGO Onco Group. Thank you.
Hello everyone, my name is Shamla Anand. In my previous life I was an ophthalmologist, and more recently I'm on the non-clinical side of things. I'm working with the American Leprosy Missions with the program in Asia.
Wonderful, thank you. I think a round of applause because we made it up to the front here. So, Wycliffe, in Kenya, I know many counties are close to or have achieved elimination thresholds for trachoma in particular. But what are the barriers you are seeing or have experiencing in fully integrating TT services back into the eye healthcare services at county level?
Thanks for that question. I'll approach this from a country perspective, and therefore my opinion may not be applicable in other countries, so I'm just sharing our country experience towards the barriers of integrating TT into the healthcare service. So the first key barrier is limited health infrastructure in key trachoma endemic areas. And I'm saying this, I think trachoma meets the definition of a true NTD, starting where the road ends. So in areas where we've got trachoma, we've got very limited number of health facilities. So that becomes a barrier when it comes to provision of intervention itself. Number two, I would want to look at it from the human resource angle, and when especially it comes again to the surgical intervention that we are looking into. Now, being in arid and semi-arid areas, most of the health facilities are concentrated in some towns or urban setups, and this is where you find probably the few trained personnel who can conduct these surgical interventions. There are transfers that also occurs at this particular area, so you train one here today, the next time they are transferred, and then getting a replacement becomes quite a difficult task. So the attrition is also a barrier towards sustainability of this surgical intervention. Thirdly, looking at it from a system component, there is intra and inter collaboration barriers that exist in provision of this, and I want to look at it from where I sit. Within the Ministry of Health, we've got two state departments of health, one dealing with public health and another one of medical services. The ophthalmic services unit is within the medical service. The neglected tropical diseases unit is within the public health, the State Department of Public Health. Now that is a barrier because we are looking at the surgical intervention to be spearheaded by ophthalmic services when you are from the NTD point of view. So that collaboration needs to be well looked into. Looking at it from another perspective, as we approach it from, we also need collaboration from the various non-governmental organizations and stakeholders. As Angelia put it, we've got our ways, they've also got their ways. Now when these ways are not really coming into a common objective, then it becomes a barrier towards achieving the same objective. Secondly, I want to look at it also from the patient perspective. And the first barrier that I see from observe as we move towards this is the fear from those who are already affected with trachoma. I'm an entomologist, parasitologist. My background is in that. So we deal with insects. So sometimes when we trap insects, we knock them off a bit before you study. And the perspective of our community members when it comes to surgical operation is that the doctors or the surgeons also want to knock off a bit before they do any intervention. Now, from the perspective, knocking me off, sometimes I may not wake up at the end of it. So the fear, stigma, when you just term that I want to perform surgery, becomes a real nightmare. So looking at it from a perspective where we are now downscaling our campaign, and we want to look at it that an individual that impacted by trachoma is coming to the facility, that stigma, we really need to look into it. Secondly, we said with the limited infrastructure, these patients are coming from very long distances from the health facilities. Now the transportation to access this intervention, looking at it from the last mile, is also another key barrier from individual perspective. Lastly, I think there's also a number of cultural and religious barriers that exist in areas where trachoma is endemic. So probably those are some of the insights on the barriers that we have or observed towards trying to integrate the TT surgeries into the healthcare system. Thank you.
Thank you very much, Wycliffe. So I think what we're seeing is a lot of the problems and barriers you're facing as it becomes now back to the ownership of the eye healthcare system are not dissimilar to those that we faced during the public health campaigns, but we should coordinate early and look at early solutions that can be implemented as we're still carrying on the campaigns, and then as it rolls back into the eye healthcare system, we hope that these stigmas and barriers will be lessened through experience over the years. It's really interesting.
Very true.
Yeah. And Teo, in Nigeria, I know you've made massive progress in the elimination of trachoma. How have NGOs promoted and supported the state eye health systems to take ownership of TT services, the big rollout of transition, if you like? And have the ICTC transition toolkits been useful or not? We'd love some feedback.
Yeah, thanks, Michaela, and I'm glad that Wycliffe came first to talk about some of the barriers, because for us to be able to integrate the TT services into the eye health system is first of all identifying what are the challenges, where will we start from, and at the state level, the first stage really is to see how can we bring all partners and stakeholders together so that they understand the need and also come together and strategize on how to work together. So first would be to ensure that there is that advocacy and awareness and ownership between the partners, the eye health and the trachoma program under the NTD. He's actually said that yes, in most areas we find that the NTD takes charge of the trachoma implementation under the public health unit, but for the TT services, usually the eye health employ the surgeons that would provide that service. So there is need to bring them together, identify how they can work together and sustain the services that would come even after transition. So using the toolkit helped to, provide guidance on what we need to do. So at the state level, we started with plans for transition early. And I like the acronym START early because that is what really leads to sustainability. So starting early, the plans might be grand. We've seen that in some states they had very grand plans like having static centers everywhere, making sure that it's in almost reachable within clusters of communities. But when you start thinking of sustainability, because donor funding wouldn't be there for long. How are they able to, the state teams are able to sustain it? So the reality of sustainability plans starting at, that has started at the beginning of implementation had to evolve as time went on to what exactly is realistic. What can the iHealth system really take on? So we've seen changes even in approach to documentation, data management, and all of that had to go into the transition plans that are available in the toolkit. We've also seen how the models and the templates that are in the toolkit have also been adapted at each state level. So you find different states with different strengths. Some states can actually sustain and provide resources. Some states need to provide some incentives and also look for ways to get user fees to be able to sustain the services. So all of that are the plans that we needed to use the toolkit to be able to develop state-specific transition plans, and both the iHealth system and the NTD trachoma system had to come together to see what would work. How would there be linkages? One of the ways that we ensured that these linkages are sustained is to strengthen the DHIS2 system, both for the iHealth and also for the NTDs, to ensure that this changes, this progress we've made while implementing is sustained even during, after the transition process, and to ensure that surveillance is maintained and tracked, because that was one of the reasons why, the iHealth system has to come in. And so to make sure that once we're trying to ensure that the surveillance is maintained, even their own data management system has been upgraded to adapt the trachoma indicators to make sure that we're able to make to have our documentation maintained for elimination. Thank you.
Thank you, Tael. Just a couple of follow-up questions, two very diverse ones. Getting into indicators into the HMIS, how long did that take, and who did you have to involve?
So that is still ongoing. It's not. It hasn't. We've not gotten there, but we're definitely. We have started. So we had to get at the national level, because the HMIS system, starts at the national level. And when we looked at the need at the national level, we didn't have adequate indicators that captures the trachoma implementation for not just implementing, but also for sustainability and surveillance. So we had to start at the national level. The whole NTD program started with including the community health information system into the DHIS, to piloting across different states to see how we can strengthen it. And then we now started, on the other hand, at the national level for the iHealth, because that system had its own gaps also. So having to support both, iHealth and NTD system helped in the integration, really. So it's still ongoing. Even for the iHealth, we started piloting in some states, and we hope that by the end of this month that is completed. And we're happy that we followed on in the iHealth data management system. So yes, it's ongoing. What we have tried to do at the state level is find out what data system exists at the state level. How can we ensure that this documentation is not lost, even as we're reforming the national systems? So it's working with how much information can be gathered and stored at the lowest level, that's at the health facility level, strengthening that data system at that point, so that once we have the overhaul, historic data is available.
Brilliant, thank you. And not to delay moving on, but one other question. You mentioned about the introduction of user fees, and I was lucky enough to be in Nigeria at the last meeting. I was hugely impressed by each state's presentation of how they're handling the transition. And they've introduced user fees. I think it was about 2,000 for one eye and 4,000 for two. And it varied across the states, of course. But have you seen that in action now? Have people actually started paying for services for TT surgery, or this is the introductory phase?
So user fees for TT services, I wouldn't say is introductory because of the private sector. So there are some places they go and they do pay for services. So, but when it comes to the public sector, yes, some states are now considering the user fee because they know that with donor funding, it might not be there all the time, so they need to introduce it. And some states have started using it. In fact, some have come back and found out that what they had set might not be realistic. They need to increase it. Some have gone on to look for other local supports, like donors within the communities, to see if they can, support user fee, even if like an incentive. So yes, it started in some places. Some places have come back and said, we need to change it, we need to increase it. Some have said, oh, we have funding this year, we can leverage on some other services and people don't need to pay for it. So we're constantly seeing some changes. But the good thing, I think, is that states are engaging by themselves, looking for ways that we can make it better. And then they are also leveraging on systems they have, like revolving funds within the local levels, to see that they're sustaining care for TT.
Fantastic, thank you. And over to you, Franca. Mitasat, another fantastic NGO in Nigeria. You work both in onco and trachoma, as well as other diseases. But what do you think the two diseases can learn from each other as sort of between an entry point into the health system through eye health? How have you managed to learn from one disease to the other, or do you find it quite separate?
Thank you, and thank you for the opportunity. I'm glad that at this meeting we've encouraged storytelling. So I'll try to do some storytelling, 2 scenarios about onco and trachoma. So when the global trachoma mapping project started in Nigeria, the states were at different stages with their eye health and health system. You had some that were doing very well and some that were still struggling. So let me start with the one that was doing very well. In Niger State, when the global trachoma mapping project came in, their eye health was already working. They were doing campaigns, maybe mobilizing local resources and all of that. But of course, they didn't know the body. So we leveraged on that structure, the eye health structure, and they supplied the human resource that were trained, of course, improved upon. They knew the backlog. So they were excited, and we worked with them, and the backlog was cleared. So now, talking about transition, Dr. Tehi won't let us go. So there was a lot of emphasis. Site-savers pushed a lot, with all the partners, that you must make sure the transition is working. And don't just tell me on paper, I'll find out. So all the state people were, and the government, of course, the Federal Ministry of Health, they were all engaged. So the states now, that particular state, now that we're talking about transition, they are part of it. So we finished, we cleared the backlog, and the assessment results, impact assessment was successful and all of that. So now they are part of the group, they are back. And the interesting thing is that when the global trachoma mapping project started, we were told that patients identified during the mapping, I'm looking at Michaela, will be cleared. And that was followed. We got support and we were able to clear the backlog that was identified at the mapping stage. So when we went back to clear the backlog, the numbers that were found were less, because immediately after the mapping, we worked, Microsat and the state government worked together and cleared some backlog. So that system has been there and remained. So in transition, it's just like handing it back to them. And they've had their meetings. In fact, they're still meeting this week. So it's seamless. The same system, health system, they've taken back the challenge and they are working. And they are just asking for more. They have said, oh, if there is support from the program, they want more surgeons to be trained. They want more headsets and all of that. But I don't think they would not be able to look for local resource to do that if they don't get external funding. The reason being that we met them there and they are working. And they are also part of the ONCO structure. They also attend our meetings, review meetings, so that's fine, it's working okay. Now there's another project, and that's the Taraba project. That's a very difficult one. It's like, it was really tough, starting with Taraba because of the terrain. When we're talking about how to reach communities, you have a lot of them. We had surgeons that we had to carry their equipment. People had to back them. Practically, we have the pictures, across the river, trekking miles to be able to get the services. But we are glad that it worked well. But what we found when we started the mapping there is that the eye health structure was not well established. They were struggling. The established one was ONCO, because onchocerciasis was where you had a lot of blind people due to onco at that time. So the established eye health program was onchocerciasis program. But global trachoma mapping, working with SciSaver, we leverage on that. So it was the onco structure that provided the human resource. They provided the surgeons, some of the local onco coordinators were trained at nurses that were qualified. So we used the onco structure. Of course, the backlog has been cleared. So what has happened there? Now we are going back to the onco structure, but you still have to strengthen the eye health. We need to strengthen the eye health. One of the collaboration that happened was that the transition meeting leveraged on the review meeting they have. The onco review meeting in Taraba 2 years ago was used to set up transition committee meeting. So they are working together very well. So, but that gap still remains, that we still need to ensure that their eye health is strengthened. Those that know Taraba Zinc, you know that there's really human resource gap. And they have said it at meetings that please, they need to be strengthened the more. The other thing I want to say is local intelligence. We have an experience. Taraba and Adamawa, sorry I'm using our local, but this is, those of you that do not know Nigeria very well, you may not understand, but this is like second level administrative structure. Yes, so if you want to use the eye health facility, you have to pay more going through roadway and all of that. But the local intelligence shows that you just need to cross a river to move from Taraba to Adamawa. If you use the local intelligence and you are dealing with hard-to-reach areas, that was what happened. So we had a partner in Nigeria, Helen Keller, was working in that state, and we were working in another state. Microsat was in Taraba, Helen Keller was in Adamawa. But the local people can just cross a river and access the care. The onco people called on him and said, we don't need to travel all the way to the state capital. Can we just cross the river and access the program in Taraba? And Jabo gave me a call and said, why not? We can do this. And within 1 week, they were able to access services just by walking across the river. They didn't have to pay transportation. So what am I saying? There's local intelligence. We can get to the hard-to-reach areas. We trekked. I think the billboard is there. The Microsat, we trekked for 6 hours. We had young people that liked climbing mountains. And we had to trek to go and do what NTD did. We have the banner there. So what I'm trying to say is that I always tell Martin, I said, you people are ahead, trachoma. There's a lot to learn, and I'm glad it's coming out here. The onco community will continue to work with trachoma because it's the same eye. It's the same eye. In the endemic community, exposed to the same environment. So, but I'm glad for this opportunity to share my experience. Thank you.
Thank you, Franca. That's fantastic. It's definitely the same eye. It's often the same health personnel that we're working with. So strengthening through a trachoma program or an onco program, we are working with the same human resources. So that can be advantageous because there's multiple resources going in, but that can also be an additional burden because each program pulls on a resource personnel at the same time. So we need to be mindful of that, I think. But it should certainly be a benefit as the programs, should we say, wind down because it's no longer a public health problem. So it's something to look forward to. But perhaps moving continents now to Dr. Sharmila. You know, working in the leprosy community, it's slightly different approaches perhaps to what we've been discussing on trachoma and onco. And I believe you work with more specialized eye health units. What do you think we can learn about your interaction with those eye health units and how you prepare them for sustainable work? Perhaps when the donors leave, shall we say, as well?
I'll speak from my experience in India and in Nepal.
She'll be eating it if it's any closer, I think, but we shall try.
I wish there was something to wipe this with, like a sanitizer.
Do we have any sanitizer, anybody? Well, I've been using this.
Okay, so nothing against you at all. No. Thank you.
Yeah.
Thank you.
It should actually be the best practice.
Yeah, it should be a preferred practice in the trachoma. Okay, so leprosy is a very rare disease. It's fast becoming a really rare disease, and ocular complications in leprosy are even rarer. No one really knows what the estimates are because the estimates that people say are really from small population studies and maybe 10 years, 7 years ago. So though we are finding cases earlier and treating them earlier, it doesn't mean that that's going to prevent eye complications because they're going to happen anyway as part of the disease process. With the nerve damage, it's lack of thalamus, which is an inability to blink. And with the reactions in leprosy, it's a uveitis, which is an inflammation in the eye, just to put it very simply. So these are not complications that any ophthalmologist doesn't know how to treat. In Asia, the eye care programs are very strong. They have good reach everywhere, so it's just a matter of referring. But there are two levels to prevent blindness in leprosy. One level is the patient, because there's a certain category of patients who are high risk. So the main thing is to know who is high risk and to really educate that patient to be very vigilant so that they can report the minute they know. And then the next level is the primary level, who's the health worker who's actually going and giving the NDT or the strip of tablets every month. So these people need to know who the high risk patients are. So basically those that they can recognize and refer. So that's all we really need. If these two levels are really strong at the ground, the patient who is high risk and the health worker who knows who their high risk case is. Because people with leprosy, they live really scattered in the community. So it just might be 1 or 2 people in 1,000, like one ASHA worker in India has 1,000 population. So it's not that many people. So it's a matter of focusing there. When it comes to referring, the secondary level at the district level in all government hospitals in both India and in Nepal, there are ophthalmologists who are competent to handle. But I want to say that when you ask me this question, we really don't have evidence because you refer people, you don't know if they really went. And then the second thing is you don't really know whether they got the care. And since she told a story, I can tell mine as well. So in 2017, when I moved to Hyderabad, which is the city where I now live, I was volunteering once a week in a leprosy eye clinic. That was just doing the non-clinical aspects. And I saw a man who was bilateral cataract blind. He was in his 30s, and this was because of the steroids he'd been taking for his reactions for over several months. He'd been self-dosing on them. And I immediately referred him to the very next door hospital in the same compound. It was a charitable eye hospital. And 3 months later, he came back to me, and he was still bilateral cataract blind. And they hadn't done his surgery. And it was not because the doctor didn't want to, the management didn't want to. So I raised a bit of a hue and cry. I sort of dug up that this had been established to be a charitable hospital open to everyone. And I got his surgery done. They also asked me not to volunteer at the clinic anymore. So what I want to say is this is like my first experience, ever experiencing something like that, because this is what I'm saying. This was not a government system. This was a charitable hospital. So you might be referring to an NGO hospital, but you really don't know. So I think follow-up is the important thing. But I would really like to collect the evidence on how much this referral thing really works. So that's about it.
No, thank you. That's fantastic. And I like the fact you highlight it's very rare for you to see complications, eye complications in your sphere, if you like. And TT is going to become extremely rare. I think there is a fear amongst districts that as we transition, the reason we're transitioning is because it's no longer a public health problem. You no longer need a public campaign to go house to house to find all the cases. And so in fact, the number of cases that you're going to be getting is very low. And I think if we can start, we are gathering, I think the community is gathering data on this, be it in the HMIS or be it in our own, in our manual systems. And we can start to analyse what are exactly the numbers we're getting. Now there's a whole host of factors that may affect that, but it would be great in terms of promoting to districts that you can take care of incident cases as they come. It is not insurmountable, and it's extremely possible. I think leaving behind, the awareness of the disease and the sort of health-seeking behaviour of those that would need to go and get some assistance is really important. So identification of perhaps TT or something else is also needs to be instilled before we transition. So again, we start at the beginning. You're raising awareness about the diseases before you start the campaigns, and then as you phase them out, it's equally important. So those are sought. And then the barriers about, well, I know that I've got to go to the doctor, but if he's going to knock me down a bit, then I don't want to go. But hopefully during the campaigns, they learnt from their neighbours, their sisters, their mothers, that actually you don't get knocked down. You maybe, but you get up again, and there's a song about that. But you can. It is, it's such a fantastic life improvement. So it's interesting. I think the different states have different capacities when we start. Hopefully, those capacities across the counties have evened out after a campaign. But I wanted to open up the panel to any questions from the audience around this sustainable. Gilbert, always the chatty Gilbert. We love you, Gilbert. We think you're going to overtake Martin in terms of chattiness at meetings. A little silent bet going on. But we welcome it, and that's part of the family. So over to Gilbert. Yeah.
Thank you. My name is Gilbert Baena. I'm from the Fred Hollows Foundation, and I do trachoma most of the time. Looking at this great panel, who are also my friends, I worried whom I should ask, but I think Omondi won't mind a lot. Eh? He will not take me to task. So thank you so much on expounding on the barriers. I just wanted to give an experience on the provider side and get your comments. During a few years ago, I went to one of the most trachoma endemic regions to look at work being done by this ophthalmologist who was excited to invite me because she knew she was doing a great job. And in the area that they were doing an integrated eye care service. They had 6 tables. I was excited, everything looked good. But then I noticed all the surgeons were doing cataracts. Yeah? So I asked, guys, this is a highly trachoma endemic area. Where is the surgeon doing the TT surgery? So now he's out there in the back in one of the other rooms. And I went there and found the surgeon. So number one, you have 6 tables taking care of something else. Trachoma is only one. Again, provider side. 2, the surgeon I found had been imported from another region. Okay? So capacity in this endemic region, I was worried about that capacity. Yet some of the 6 surgeons were trained in TT surgery. So I asked, guys, why aren't you doing the TT surgery? I got a whole lot of reasons, but one of them was, we lack equipment. Then we checked the equipment that they had packed, and the equipment was there. Okay? The equipment was there. The other reason was the other guy is too good. So instead of joining the guy who is too good to improve your skill, you're over here doing the cataracts. Cataracts are important, yes. But I'm looking at the spread as a manager like yourself. Then we went to, it takes long to get the patients and issues like that. But at the end of the day, human resource issues came in. If you are an ophthalmic surgeon, you do not get promoted. You don't get better pay. Yet the guys who are in the other room have got opportunities. Okay? So on the provider side, have you had such an experience? If not, what other issues on the provider side have you been able to detect? Thank you.
Okay, thank you so much, Gilbert. That is a friendly fire. But I do agree with you, and if you looked at some of the barriers that I indicated was bordering the health infrastructure, human resource, and that is what you are acknowledging, that probably there was the ratio of who was doing the TT surgery to other surgical operations was low. From the transition talks, and what we've been doing is to see how we can capacity build the second level or tier of government, which is county, that is tasked with the implementation of health services in the country. And therefore, what I want to maybe share is that the program is working very closely with the county to identify the surgeons who can be capacity built to undertake TT surgeries, and therefore that means that we can ride along the cataracts operations alongside the TTs. So maybe this was what you observed years ago, but moving forward in sustainability gains, we are looking to rectify into this. So again, what I want to say that we may not be able to control is in terms of the pay. That one is very difficult to control from where we sit. We can only try to capacity build to ensure that there is a HR to take care of these cases, but when it comes to pay, it becomes difficult. Number 2, when it comes to one wants to exit, you've trained, but then they've seen a greener pasture somewhere. So again, that becomes very difficult. But the program is putting up that continuous capacity building to ensure that at least we have a pool of trained surgeons to take care of these residual effects. Thank you.
Thank you, Wycliffe. That's fantastic. And I believe Martin has a question. Thank you. Did I predict that? Go ahead, Martin. You're welcome.
I can't get driven away like that. No, thanks so much. I think this is an absolutely timely discussion. I really appreciate ICTC's bringing this up. Onco and trachoma kind of have historically emerged out of eye health, and also leprosy has been closely linked. I, as an ophthalmologist, have done my first cataract surgery at Alert, in a leprosy unit that has then developed into a serving general eye health. So we all, the three of us, we depend on good, effective eye health services. So my general question is, what can we do together, with all the different epidemiology and location, whatever, to actually ensure and support governments in bringing effective eye health services to the people who need these effective eye health services. So what can we do together? Let's get out of our silos and come together, because we have a common road here that we are all depending on. And the thing that I see there, one is, how do we maintain the expertise with increasing the rarity of those complications? In onco, and still we have them. With TT, but they still will come up. With leprosy, they will still be there. So how do we maintain the expertise, and how do we maintain it as close to the people as possible, but at the same time, how do we, and I appreciate you brought this up, effective referral systems. How do we make sure that people who are identified to need the services actually get those services? So tracking systems like we have developed for trachoma may well be something to look at from the onco or even the leprosy side. If we do this, then the next thing is really funds. I think we need to look at this. There are all those big funding initiatives that we had in various places that have served to provide free of cost services. That will probably not be the case in the future. So can we just ask them, like I hear from Nigeria, to charge? Or is it maybe we have to really engage, the three of us, trachoma, onco, and leprosy, into alternative systems, like developing local insurance systems, something like that covers, for example, those and sometimes with the inflammation in the eye, right, complicated things that cannot be done at a very peripheral level. So I think we need to come together to help and work together with eye health to push for those things at those three major areas that I at least have seen. So thanks again for bringing this up and coming together as a community here.
Thank you. Right, time for, I was going to say, Martin has summarised fantastically the challenges we face and how perhaps we can move forward, thankfully closing my closeout speech. But let's have one last question. This gentleman here versus the lady here, sorry.
Okay, thank you. I think I'm just going to talk on some of the experience like in South Sudan and EAC. If you can permit me to do this, I'm not going to be speaking on behalf of the government, but just as an individual who comes from that country. So I think it's just going to be like on the trachoma community, looking at sustainability and looking at transitioning that we're talking about into the health system, and ensure like the countries own this as something that is being streamlined to the health system that is existing in the communities. So from my experience in South Sudan, I can really say high care is being neglected as well. Yaki will correct me for this. And even the personnel that we have there, things that we were talking about, attrition and motivation, is part of the challenge. Like, these people are not even recognized, they are not even paid, like nobody is really even looking after them, but they have a lot of things to do in the country. You talk about cataract, you talk about TT, and many other eye care services. So I'm just trying to look at, like overall, I can say probably people who can operate TT in South Sudan, like the surgeons, could be either 10 or 15 people. Just look for a population of maybe 11 or 12 million people. And out of this, probably 8 or 6 states are endemic, hopefully for trachoma. And obviously you will have TT cases within these areas. So what is the thinking of the trachoma community, like in terms of advocacy, really trying to see if there's a way we can advocate for resources and maybe support the government to really have trainings, like build their capacity, especially for those who are already doing essential services. Like we have clinicians, we have doctors like all over the country who are doing like the essential, these other health services. If we can just pull resources and just train the TT procedure to those people, just have them train for TT procedure, so that when a patient comes to a clinic, this person is able to get services just on daily basis, like any other routine care. I think other than the silos that somebody's saying, like we go for an outreach and you stay there for 10 days, you operate 300 people, and then it stops for another 1 year if you don't move there. But there are other people who could not come during that time. And there are also other cases of recurrence that comes within the community. So they have to wait for another 2 or 3 years to get services. So what will happen? These people eventually will even go blind. So I'm just trying to see, like, there are really resources in the community, but they don't have the capacity to even identify that this is a TT case. It's not there, but these people are coming to the facility. So when we're trying to look at doing MDAs and finding ways to do things, let's also think of really advocating maybe for resources to support the government to really have this kind of like the procedure. I can just talk of TT, like the TT surgery being like the capacity of the people in the ground need to be built, and they are able to do this. Thank you.
No, absolutely, thank you. The words I've heard, apart from starting early and ensuring sustainability, which I know you're all going to quote as soon as you leave this room, is coordination, advocacy, capacity building, getting the right stakeholders in the room early enough. And that starts on day 1 of any elimination program, not day 20 or as we've achieved elimination thresholds. So I'd just like to, we've got a lot to learn, we've got a lot more to discuss. I think doing this in 35 minutes was quite a challenge, but I really want to thank our panelists for rising to that challenge, and a huge round of applause, please, for them. So we'll be closing our open meeting now, taking a coffee break. So please go and enjoy yourselves in the coffee break. Thank you again for the interest and for everyone participating today. We will be having a closed session at 11:15, I believe it starts. 11 o'clock. And that is for members and observers who have registered. It is not, I'm afraid, open to kind ministries and partners that are not members at this time. But thank you so much for coming. We also hope to have perhaps a longer ICTC meeting at the next either GET 2020 and or back-to-back on the NNN to take advantage of all the inputs from the other diseases and those that are interested in trachoma to discuss more widely the issues that we face. So thank you very much. And see you later. Thank you very much, panelists.